Good morning, everyone. Myself, Dr. K. Radhika, today going to speak about a study of Barrett's 2 versus SRKT formula to calculate IOL power using immersion ultrasound biometry. There are no financial interest. Introduction, cataract surgery is considered as a refractive procedure, so estimating the intraocular lens power accurately is crucial for cataract surgery refractive outcome. One of the commonly used formula, the standard Ritzer and Kraft theoretical formula that was introduced in 1990s, formulated as a combination of both regression and theoretical approach, has been found to be accurate, particularly in eyes with axial length more than 27 mm. The Barrett universal formula, an updated version of BU formula, was introduced in 2010 by Graham D. Barrett and has shown promising results so far. Aim is to compare the predictive accuracy of refractive outcomes after cataract surgery using SRKT and BU2 formula. Objectives to assess the refractive outcome after cataract surgery using SRKT formula, to assess the refractive outcome after cataract surgery using BU2 formula, and to compare the refractive outcome after cataract surgery between SRKT and BU2 formula. It's a cross-sectional analytical study with sample size 60 patients, 30 patients in each group. Patients were randomized into two groups using random tables. Study duration is 10 months, done in a tertiary hospital. Inclusion criteria is patient above the age of 50 years, existence of age-related immature cataract based on LOX3 staging, and no history of previous surgery of anterior or posterior segment of eye. Patients with retinal or corneal pathology, traumatic cataract, congenital cataract, complicated cataract, glaucoma, squint, corneal degenerations, high corneal astigmatism were excluded. Patient demographic details have been recorded, and all patients have undergone a complete ocular examination, including best corrected visual acuity, IOP measurements, slit lamp examination, and fundoscopy. Biometry, IOL power calculation by A-scan ultrasound by immersion method, and ARK mission. All patients have undergone standard FECA emulsification procedure with 2.5 mm incision, and implantation of foldable IOL is done. All surgeries were performed by single surgeon. Only uneven full surgeries have been included. BCVA is measured at post-operatively 6 weeks. Refractive error predictor versus obtained was tabulated. Comparison of outcomes in both groups were recorded. The collected data was entered and analyzed using Microsoft Excel 2019. Independent sample t-test was used to compare the means between two groups. Bland Altman plot was constructed to see the agreement between two formula of IOL power calculation. And the mean age of my study is 63.81. The predicted error does not have the mean significant difference, whereas obtained error between SRKT and BU2 formula has mean significant difference, p-value less than 0.01. Whereas in SRKT group, there is mean significant difference between predicted error and obtained error. And in BU2 formula also, there is mean significant difference between predicted error and obtained error. In a bland Altman plot, we can see the 93% confident interval. Discussion, in the present study, the Barrett universal formula provides a better predictability of IOL power calculation than the SRKT2 formula. In Demena et al., the study concluded that Barrett universal 2 formula outperforms both the SRKT formula and Hage's formula for highly myopic eyes. Whereas in Kutimarol et al., the Barrett universal 2 formula performed as the most accurate formula in the prediction of post-operative refraction over a wide range of axial lengths. The limitation of study is, although immersion ultrasound biometry was used in this study, optical biometry is often preferred for assessing ocular parameters in order to determine the IOL power using the BU2 formula. The conclusion of the study is the Barrett universal 2 formula provides a better predictability of IOL power calculation than the SRKT formula, clinically helpful for improving the refractive accuracy post-cataract surgery. These are my references. Thank you.
So, which is one common thing between Barrett 2 and SRKT?
In SRKT, we use theoretical and regression. Both are calculated in the this thing. We do not do it manually. It is done only in a biometer, or we will have a calculator.
So the machine uses regression formulas and arrives at a particular value.
Yes.
In both.
Both.
Okay. So and that is the ability, and what is the inability that is common?
Inability is in Barrett's we want AC depth, which is better, can be done in optical But
Yes.
even immersion ultrasound biometry, you can have the AC depth. Because in nuclear dense cataracts, we cannot do the optical biometry cannot analyze the AC depth and axial.
So in all the formulas for IOL calculation, which is the one factor which cannot be measured by the existing machines? The effective lens position, that cannot be assessed by any machine that is available right now. Yeah. Thank you.